Welcome back to our USMLE question of the day. As always, we start with the last sentence, which is the question of the vignette, and then we know what the question is going to be asking us. Which of the following would most likely be found in the biopsy of this mass? A 20-year-old woman presents to her physician's office with a small, firm mass in the lower inner quadrant of her right breast that seems mobile when palpated. It is not tender. There are no overlying skin changes or nipple discharge. She has no family or personal history of breast cancer. So which of the following would most likely be found on biopsy of this mass? Take a minute, read the question again and the answer choices, come up with your answer, and put it in the comment box below. Okay, so the first thing we're going to do is we're going to find the things that are most important for us in this question. So age, 20-year-old female, has a small, firm mass, and the location is in the lower inner quadrant of her right breast. It is mobile, it is non-tender, and then there's no skin changes or nipple changes associated with this. We can also see that there's no personal or family history of breast cancer, so we don't have some risk factors. So let's look and see what could our possible answers be. Starting at the top with A. Blue dome cysts and some atypical epithelial hyperplasia. Blue dome cysts are classically found with fibrocystic change of the breast, and I don't believe this is fibrocystic change of the breast, so I'm going to eliminate answer A. B, cells in a single file form. That is classic for infiltrating lobular carcinomas. I don't think this is a carcinoma at all. I think this is probably more like a fibroadenoma. So we're going to mark out B because this is not a classic cancer presentation. C, fibrosing stroma around normal-looking glands. That is a very good example of what a fibroadenoma is because they're small, firm, mobile masses. So they have normal glands around them with some fibrous stroma. So I think C might be my answer. Let's continue on and read the rest of our answers first. D, large cells with clear halos. That's Paget's disease. No, this is not Paget's disease of the breast because of the skin. There's no skin changes. And then E, multicentric lobes with lymphocytic infiltrates. Lymphocytic infiltrates are classic of a bad prognosis with a cancer specifically, and I don't believe that's what we're dealing with, so we're going to mark E out, which leaves us with our final answer of C, which is a fibrosing stroma around normal-looking glands. And the correct answer is C, which is fibrosing stroma around normal-looking glands. What this is indicative of and what this question is telling us is a fibroadenoma. These are benign changes, typically in young females in the breast. It's a common tumor. They are classically described as small, firm, and mobile masses. We don't have any association with malignancy with these, and if you did a biopsy, you would see the fibrosing stroma with the normal ducts and normal glands. These blue dome cysts in A are seen with fibrocystic diseases of the breast, and specifically fibrocystic diseases of the breast do increase our risk of carcinoma. B, cells in a single file formation, as we mentioned earlier, is infiltrating lobular carcinomas. So you see either clustered or linear formations with these cells. Answer D, this is Paget's disease. And with Paget's disease, you do often see some skin findings associated with the development of this disease. And then finally, E, these are, anytime you, like I said earlier, anytime you see any lymphocytic infiltrates, that is an inflammatory carcinoma, and that inflammatory carcinoma has poor prognosis. As always, we begin with the last sentence of the question to find out what this question is looking for. This patient most likely has which of the following types of immune deficiencies? A 10-year-old female is brought to the pediatrician by her parents because of a low-grade fever. The physician notes that the girl has pale skin and bright blue eyes, which the mother states has been present since birth. The physician diagnoses the girl with a staphylococcal infection and prescribes her a course of antibiotics. 3 months later, the child returns to the pediatrician with fever and a sore throat,
which was diagnosed as a streptococcal infection. A review of the patient's medical records indicate that she has had repeated episodes of staphylococcal and streptococcal infections for her entire life. The patient most likely has which of the following types of immune deficiencies? So the key thing that we're looking for here is repetitive or increased susceptibility to staph and strep microbes. Looking at these answer choices, I would probably rule out E first and foremost, because severe combined immunodeficiency will increase our risk for more than just staph and strep microbes. I would also rule out hyper IgM syndrome, and I would rule out chronic granulomatous disease. I do remember chronic granulomatous disease does increase our risk for staph infections, but it does not increase our risk for strep infections because the problem is with microbes that create their own catalase. Therefore, I am down between A and D. Pulling more information in from the question, the patient has pale skin and bright blue eyes, which is indicative of albinism. Chetak-Higashi is associated with lysosomes, which are also associated with melanin. Therefore, my answer would be A, Chetak-Higashi syndrome. A is the correct answer, as Chetak-Higashi disease is an inherited autosomal recessive disease. This is caused by a deficiency in lysosomes emptying phagocytic cells due to defects in the microtubular function. So patients with Chetak-Higashi disease often present with recurrent streptococcal and staphylococcal infections. And the association here with albinism can be present because melanosomes are derivatives of lysosomes. As I said earlier, B, chronic granulomatous disease, does increase susceptibility to staph, but it's also to organisms like Candida due to the catalase organisms that they produce their own catalase. Furthermore, D, selective IgA deficiency, would increase our risk of sinus and lung infections, but that does not necessarily limit us to staph and strep. Finally, as I said earlier as well, our severe combined immunodeficiency increases our risk for bacterial, viral, protozoal, and fungal infections. As we have been doing, we're going to hide our answer choices until we read the question so that we don't get distracted by the answer choices. And as always, we start with the last sentence, which is our question, before we read the rest of the vignette. What insect is the most likely route of transmission for this patient's illness? A 39-year-old man living in Honduras presents to the clinic complaining of constipation and stomach pains for several months. On cardiac examination, the physician discovers a laterally displaced point of maximal impact. Chest and abdominal x-rays reveal a pulmonary congestion, cardiomegaly, and megacolon. Symptomatic treatment is all that can be offered to this patient. So what insect's the most likely route of transmission for this patient's illness? Well, we're looking for something that causes a disease that gives us pulmonary congestion, cardiomegaly, megacolon. That cardiomegaly is what's laterally displacing the point of maximum impact. He's also having constipation and stomach pains. So all that together, we're looking for a organism that's transmitted by an insect. So let's see what we got. A, Anopheles mosquito. B, Ixodes tick. C, Reduvid bug. D, sandfly. Or E, tsetse fly. Take a minute, come up with your answer, and write your answer in the comments below. Well, I know that the Anopheles mosquito transmits malaria, and this doesn't seem to fit malaria signs and symptoms, so I'm going to mark that one out. The Ixodes tick, that one transmits Lyme disease. We're not seeing any type of indication this is Lyme disease or babesiosa. And Lyme disease locations don't really fit someone in Honduras. That's going to be more in the United States, up in the northeast, towards the central portion of the United States. So the Ixodes tick, probably not going to be my answer here. The Reduvid bug, this could possibly be it. So let's leave this here and come back to it. D, sandfly. Sandflies, we see transmitting stuff, Kala-Azar, Leishmaniasis. I don't think that any of this is going to be seen with this particular patient. This doesn't seem to fit to me, sandfly. And then our tsetse fly, African sleeping sickness. I remember sleeping fly and African sleeping sickness associated with each other. I don't think that's what this is. Let's just leave it and go back here. Let's look at C, Reduvid bug. Reduvid bug, this is, if everything I remember, Chagas disease. Chagas disease gives us things that would fit here. That pulmonary congestion is a possible a side effect of Chagas disease. Cardiomegaly, definitely with Chagas disease. So from what I'm remembering seeing, I think C fits better with this answer. So I'm going to go with C as my final answer. And C is the correct answer. So this is the Reduvid bug that transmits Trypanosoma cruzi, which is what causes Chagas disease. So our acute symptoms with Chagas disease can be the chagomas, which are small skin granulomas that it's caused by multiplication of that pathogen along the skin. We can get myocarditis. We can get congestive heart failure. But then in severe cases, we can see, or severe or more chronic cases, we can see arrhythmias. We can see dilated cardiomyopathy, which is where we're going to get that displacement of the lateral displacement of the maximum point of maximal impact. Megacolon is another side effect of Chagas disease. As far as treatment goes, like we said here, that symptomatic treatment is all that could be offered to this patient. So how do we treat this? Well, we're going to treat this with nifurtimox, and that helps us with during the acute stage of infection. And oftentimes the Reduvid bug is found in Central and South America. So this fits in with the location of this patient in Honduras. As always, we will begin reading this question at the last sentence so that we know what this question is looking for. Which of the following drugs would be considered first-line treatment for her illness? A 28-year-old female presents to her primary care physician complaining of overwhelming fear and apprehension. The patient states that for the past 9 months, she's been feeling anxious and worried about many things on almost a daily basis. She states that she sometimes feels like her heart is racing, but her pulse is never above 100. She has difficulty concentrating and difficulty sleeping because she can't shut her brain off. She also says she often feels tense and restless. She denies past substance abuse. Which of the following drugs would be considered first-line treatment for her illness? So right off the bat, all of these symptoms are telling me this patient is likely dealing with generalized anxiety disorder. We're seeing the fear and apprehension. It's on a 9-month scale, feeling anxious and worried, can't shut their brain off, heart's racing, but they're not tachycardic. So we're dealing with generalized anxiety. We need to find a first-line treatment for generalized anxiety. Amitriptyline is a tricyclic antidepressant that is not first-line for anxiety. Buspirone, while it is a possible treatment for anxiety, I don't believe that's a first-line treatment. That's usually often a second-line treatment, so I'm going to mark that one out as well. Sertraline, also known as Zoloft, that definitely is a first-line treatment for anxiety. Flumazenil is a treatment for benzodiazepine overdose, but not for anxiety, so we will rule that out. And then midazolam. Midazolam is a benzodiazepine. However, this is a short-acting benzodiazepine, so we don't use this as a first-line treatment for generalized anxiety disorder, as it does have a high risk of dependency and rebound anxiety. Therefore, my answer would be C, sertraline or Zoloft. C is the correct answer. This patient is suffering from generalized anxiety, which is marked by several key factors that you must know. First and foremost, this anxiety and worry must be present for most days for greater than or equal to 6 months of a patient's life. It must affect multiple areas of their life, including work, school, family. And then we also have to have at least 3 of the following for adult patients: restlessness, irritability, sleep disturbances, fatigue, muscle tension, and difficulty concentrating. Our first-line treatments include CBT, or cognitive behavioral therapy, and our first-line medical treatments is SSRIs and SNRIs. And I know that sertraline is an SSRI, so we would treat sertraline as our first-line medication treatment. I will note that buspirone and other tricyclic antidepressants like amitriptyline or benzodiazepines are second-line treatments for generalized anxiety, but we would not use these first. Once again, we will hide the answer choices until we get to that point of the question. And as always, we start with the last sentence first and then read the rest of the vignette. What is the most likely to have caused this condition? A 56-year-old female is recovering at the hospital from a suspected bacterial pneumonia. Over several days, she develops fever, rash, dysuria, and urinary urgency. Urinalysis shows a specific gravity of 1.002 with hematuria and mild proteinuria. Renal biopsy shows partial effacement of the tuberointerstitial structures with pronounced edema and infiltration of the interstitium with polymorphonuclear leukocytes, eosinophils, and lymphocytes with papillary necrosis. So what is the most likely to have caused this condition? So we know they've been in the hospital for bacterial pneumonia. That tells me they're being treated with some type of medication, so I'm probably thinking this medication's causing this. Fever, rash, dysuria, urinary urgency, and then we're having these lab values, and then we have our renal biopsy giving us this partial effacement of the tuberointerstitial structures and all of the infiltrates into the portions of the kidney. So let's look at our answer choices. Take a minute, come up with your answer, and write your answer in the comments below. A, antibiotics. Well, just from the beginning, having bacterial pneumonia could mean that they're on antibiotics, so I'm thinking that could be a possibility. We know antibiotics can cause some problems. Chronic hypertension, probably not going to be a acute onset of all of this just due to her chronic hypertension, so that's not something I'm going to look at. Lead ingestion. Once again, lead ingestion is more of a chronic problem, not going to immediately pop up while this patient's in the hospital. I'm already going to mark that out just due to this issue. Multiple myeloma. While with multiple myeloma, we can see eosinophilic cast and other giant cells associated with it. We're not going to see this type of presentation with multiple myeloma. So I'm going to take multiple myeloma out. And then Wegener's granulomatosis. While Wegener's can cause renal damage, this is a focal segmental glomerulonephritis, not something more of an acute, probably this seems to be more of an acute interstitial nephritis. Okay, so I'm going to take E out. So that leaves me with A. So we talked about this patient's in the hospital getting medications already, so it could be a medication. The only one on this list is A, so that leaves me with A as my final answer. And A is the correct answer. So this is, as I mentioned, acute interstitial nephritis. So what we're seeing here, fever, rash, we can't concentrate the urine, so the urine has a low specific gravity. And then our biopsy findings that we saw, that is all classic presentation of interstitial nephritis. What causes interstitial nephritis? Drugs is going to be our most common cause. So antibiotics like beta-lactams, sulfonamides, rifampin, quinolones, all of those can cause acute interstitial nephritis. Anticonvulsant drugs can also cause acute interstitial nephritis. And then there's other organisms like bacteria and viruses that can cause it. So on the bacteria side of things, Staphylococcus, Streptococcus, Legionella can all cause acute interstitial nephritis. And viruses like CMV, Epstein-Barr, HIV, all of those can cause acute interstitial nephritis as well. But like we mentioned, chronic hypertension can cause some kidney issues, but it's not going to give us that interstitial inflammation and papillary necrosis. And fever and rash would just be completely out of the ordinary for chronic hypertension to cause those type of symptoms. Lead ingestion, that does damage the kidney. So this is another thing. They're going to give you a lot of things that will give you kidney damage, but they're a different type of kidney damage. So this is a chronic, long, prolonged course associated with lead ingestion and lead poisoning. That's not consistent with this acute picture that we see with this particular question. And we've already mentioned multiple myeloma and how that doesn't really fit. That multiple myeloma, remember this is our Bence-Jones proteins. And then Wegener's. Wegener's is a focal segmental glomerulonephritis. And this gives us those crescent formations. It does also give us some pulmonary disease, so that could confuse you a little bit. It does also give us some pulmonary disease, so a patient that doesn't present with any pulmonary disease but has the renal disease is probably going to mark that as an option out for you because of the lack of the pulmonary associations. Today we're going to hide our answer choices until we read the full question and deduce some sort of an answer. And as always, we're going to begin with the last sentence or the question of the vignette before we read the rest. Which of the following is a potential complication of this treatment? This tells me that all I'm looking for is what the treatment is, and the rest I probably don't have to pay much attention to. But let's go ahead and read the question. A 30-year-old patient comes to the physician due to a bump in her neck. Physical examination reveals a solitary thyroid nodule. Laboratory studies show an increased serum calcitonin level and a pentagastrin-induced rise in the secretion of calcitonin. A biopsy confirms the presence of a carcinoma. The patient is scheduled for a total thyroidectomy, which of the following is a potential complication of this treatment. So we're being told that the patient will be having a total thyroidectomy. Sometimes these questions may not give you the choice that they're having a total thyroidectomy. They may have you deduce that the total thyroidectomy is occurring, and then you have to find out what the complications of the treatment is. So you can't just ignore everything. But in this case, we're told there's a total thyroidectomy. What are some potential complications with a total thyroidectomy? Well, we know there are nerves that run alongside and close to the thyroid. So if we do a thyroidectomy, we can lacerate some of those nerves. I know the parathyroids sit around the thyroid as well, and some other structures in that area, muscles and whatnot. So let's remember those things, and we'll take that into consideration as we check our answer choices. All right, A is acromegaly. B is cretinism or cretinism. C is hypertension. D, hypoparathyroidism, or E, renal osteodystrophy. Take a minute, come up with your answer, and write your answer in the comments below. Well, right from the start, I'm seeing D as a potential answer here because we mentioned parathyroid as we were working through this question. But let's go through and try and eliminate some of these options. So let's start at the top. A, acromegaly. Acromegaly, this is an excess of growth hormone, mostly going to be in adults. Their growth plates have already fused. There's no association with a thyroid or a thyroidectomy in this situation. So acromegaly, I know, is not going to be my correct answer. So we'll mark that off the list. Cretinism. Cretinism is a hypothyroidism, but it's a hypothyroidism of a fetus. Okay, this is going to be due to problems with the thyroid functioning and the thyroid developing It's not going to be something a 30-year-old patient will find due to a cancer. So cretinism to me is not going to be a good option here as well. C, hypertension. While we know hypertension can be caused by a lot of things, taking a thyroid out is not going to be a cause of hypertension, so that's a bad answer. Let's skip over D for just a minute and go to E, renal osteodystrophy. So renal osteodystrophy comes along with patients that have renal failure. We can see a lot of the signs that are associated with something that could have been caused by removing the thyroid, but I don't really think we're going to have a lot of issues with this being caused by removing the thyroid. So in turn, my answer is going to be D, hypoparathyroidism. And that is our correct answer, D. So what we're seeing here is the parathyroids sit on top of the thyroid. So if we're removing the thyroid gland, you have to be very, very careful to not remove the parathyroids, and oftentimes it's still pretty almost impossible to do that. So we do have a potential to have a secondary hypoparathyroidism due to that total thyroidectomy. What will be some signs and symptoms that we'll see the patient having when they have that total thyroidectomy that affects the parathyroids? Well, hypoparathyroid can lead us to hypocalcemia, and then on top of that, we can have hyperphosphatemia. So what is the hypocalcemia symptoms? Tingling in the lips, tingling in the fingers, muscle spasms. They can have a positive Chopstick sign. So if we tap on the facial nerve in the cheek, that will cause contraction of the facial muscles. And they can also have a positive Trousseau's sign, which is when you occlude the brachial artery in the upper part of the arm, it's going to cause a carpal spasm down in the distal portion of the arm. Now, as we mentioned, renal osteodystrophy, that can give us some signs and symptoms that would be similar to hypoparathyroidism. However, this is a completely different mechanism that's causing this hypoparathyroid signs and symptoms. It's not due to the actual removal of the thyroid. Okay. As always, we start reading on the last sentence of the question so that we understand what it's asking. This patient has developed which of the following? A 75-year-old male with a past medical history of type 2 diabetes, a body mass index of 30, and a previous myocardial infarction 15 years ago, presents to the emergency department with crushing substernal chest pain radiating to his neck and jaw. An ECG reveals ST segment elevation and leads V3 and V4. Emergency cardiac catheterization with percutaneous coronary intervention, or PCI, shows a 99% occlusion of his left anterior descending artery. The patient remains stable after PCI, and the echocardiography shows a mildly impaired ejection fraction of 43%. 5 days later, the patient becomes acutely hypotensive and dyspneic. The physical exam reveals a high-pitched holosystolic murmur, loudest at the apex and radiating to the axilla, that had not been present on previous exams. An emergency echo shows an ejection fraction of 25%. The patient has developed which of the following? Well, I know that we are dealing with one of the complications that's associated with myocardial infarctions. Specifically, in this instance, we're talking about 5 days after our myocardial infarction. There are 3 specific things that are associated with days 3 to 14 after a myocardial infarction. Those 3 things are an interventricular septal rupture, a left ventricular free wall rupture, and a papillary muscle rupture. Therefore, I can rule out A, B, and F as possibilities, as those do not fall within this normal time frame. At this point in time, to be able to distinguish between an interventricular septum rupture, a left ventricular free wall rupture, and a papillary muscle rupture, we need to look at furthermore into our symptoms. High-pitched holosystolic murmur that's loudest at the apex and radiates to the axilla. This sounds to me very much like a mitral valve regurgitation. If you remember your locations of where to listen to each valve sound and which heart sound, the apex of the heart is where you hear the mitral valve the best. Therefore, to me, we have mitral regurg associated with a myocardial infarction 5 days after we're dealing with a ruptured papillary muscle, E. E is our correct answer. This patient has suffered a rupture of one of the papillary muscles in the left ventricle. This is a common complication that occurs within 3 to 14 days after a myocardial infarction. This papillary muscle anchors down the mitral valve, keeping it from flopping back into the left atrium on systole. When the papillary muscle is damaged, the mitral valve can flop back and allow regurgitation into the left atrium. This will cause a holosystolic blowing murmur that's going to be loudest at the apex, and it will radiate to the axilla. This also will explain our reduced ejection fraction, as our heart and our left ventricle are not pumping as much blood out of the heart as it is back into the left atrium. We're also seeing dyspnea in this patient that is classic signs of pulmonary edema due to the mitral regurg. The answer is not a ruptured left ventricular free wall, because that typically will lead to tamponade. And our ruptured intraventricular septum is going to lead us to a left to right shunt.
As always, let's look at the question first, which is the last sentence of the vignette, and then we will go back and read the rest of the vignette so we know what we're looking for. Which result, although not diagnostic, is most commonly associated with the patient's condition? A 50-year-old African-American woman presents to your office because of shortness of breath and fatigue that has worsened over the past 4 weeks. Over the past week, she has noticed the appearance of subcutaneous nodules on her lower extremities. Physical exam reveals flat, elevated lesions on the lower extremities bilaterally. Chest auscultation shows dry rails, with a chest x-ray showing bilateral hilar lymphadenopathy. Lab tests are performed. So which result, although not diagnostic, is most commonly associated with this patient's condition? Take a minute, read the question, come up with an answer, and write it in the comments below. So first of all, there are some things that I would point out that are key things to be able to answer this question that you need to pay attention to. There are some things that you can ignore, but then there are also some things that are important for this question. First off, this is an African American female. That can give us some clues as to who might be more susceptible to certain diseases. Those subcutaneous nodules are flat, elevated lesions on our lower extremities bilaterally. And then we see dry rails, bilateral hilar lymphadenopathy. Putting all of these symptoms together makes me believe that we're dealing with something like sarcoidosis. So now, let's look at our answer choices. I'm going to start at the bottom. Hypouricemia. Hypouricemia doesn't have anything to do with sarcoidosis. That's more something that we deal with as far as hyperuricemia and gout. But I don't know anything that has anything to do with hypouricemia and sarcoidosis, which I believe this answer is referring to. So I'm going to mark out E. D, hypocalcemia. I'm not seeing any classic symptoms or signs that would lead me to hypocalcemia. I do remember that sarcoidosis does affect calcium, but I believe that calcium is increased with sarcoidosis, not decreased. Therefore, I'm going to mark D out. Elevated amylase levels are most certainly not associated with sarcoidosis. We have nothing to do with the pancreas, so C is out. Elevated cardiac enzyme levels. There is some chance of some heart involvement with sarcoidosis, so I'm not going to rule this one out just yet. And then A, elevated angiotensin-converting enzyme levels. I do remember that ACE, or angiotensin-converting enzyme, is elevated in sarcoidosis, so this would be a great answer here. So something that is most commonly associated, while we can see B, that's not going to be the most commonly associated one. So I'm going to say A is my answer for this question, not B. And A is the correct answer, as angiotensin-converting enzyme levels are elevated in sarcoidosis, which is what this question is referring to. Sarcoidosis, if you can remember, does involve the skin and the lungs mostly. There are some other potential involvements in sarcoidosis as well, but those are going to be our two main organs that are affected. With sarcoidosis, we will have increase in ACE levels. We will have an increase in calcium levels, or hypercalcemia. And we can see an increased CD4 and CD8 levels in the bronchoalveolar lavages. What other things are associated with sarcoidosis? We can see Bell's palsy, uveitis, lupus pernio, erythema nodosum, and rheumatoid arthritis like arthropathy. The treatment for sarcoidosis is steroids. As always, we start with the last sentence of the vignette so we know what we're looking for. What is the physician's best course of action during this visit? A 30-year-old male physician is seeing a new patient who is a 27-year-old woman. When he enters the room, he recognizes her as someone he met at the bar 2 weeks ago. He was highly attracted to her at that time, but she left before he could invite her on a date. So what is the physician's best course of action during this visit? Read the question again, look at the answer choices, and decide what would be your answer. Put it in the comment box below. Alright, this is an ethics question. Sometimes these can be difficult. So let's go through our answer choices. A, ask her on a date. She is a patient of yours. You never to ask a patient on a date, so that is 100% not going to be the right answer. Do not actively seek that. B, continue the visit as normal. Could be the possible answer. C, refer her to another doctor. I don't like answers of refer her to another doctor ever. The answer choice of referring someone to another physician on the USMLE is almost always not going to be the right answer no matter the situation. So I don't like C. D is the same thing, but it's refer to another doctor and then ask her on a date. So I'm going to mark that out as well. Return to the room with a chaperone and conduct the visit as normal. While anytime there is a male and female in a room, it might be a good idea to have a chaperone, especially if there are situations where the patient may not be fully clothed. In this case, there's no indication that we're seeing this patient has any type of romantic feelings for the physician that could cause a problem here. So there doesn't need to be a chaperone in this situation. So I would say E is not the correct answer. So I'm going to say that our correct answer here is to just continue the visit as normal. And B is our correct answer. So basically this vignette is telling us that the physician had feelings for someone that they didn't know about. Nothing was ever acted upon. He just saw her at a bar across the room. So therefore, there's no reason we should think there is any type of relationship that already exists prior to this woman becoming this physician's patient. If that were the case, then we would likely say the physician would refuse to see her on the basis of this personal relationship. However, we can definitely just continue a regular examination without any concern for ethical situations here. Obviously, A is 100% never going to be the right answer. You don't actively seek romantic relationships with patients, period. As I said with C and D, referring the patient to another physician is not going to be a good answer for the USMLE. And then, as I said earlier, answer E, returning to the room with a chaperone. There is no indicated reason that the female had any interest in the male physician. Therefore, we don't have to behave in this situation any differently than we normally would.